Good morning and welcome to the opening session of 2011 CHEST here in Honolulu. My name is David Gutterman. I'm president of ACCP, and it's my honor to introduce the distinguished chairs of this global keynote address. This is the second year that we at ACCP have had an annual CHEST meeting that was launched with a day dedicated to global chest medicine, emphasizing the importance of international education in the mission of the ACCP. This year we have global tracks of education throughout the week, highlighting chest medicine across the world and focusing on our 4 target regions for education, including India, Middle East, China, and South America. We also have, for the first time this year, a global case report session with over 170 abstracts that were submitted from around the world describing interesting cases to share with their colleagues. All the abstracts that met the submission format requirements were accepted for presentation this year, so please view them on Tuesday when they'll be presented. I'd like to acknowledge Kevin Chan. Kevin, if you could please stand up and wave. Kevin from University of Michigan is the program chair for CHEST 2011. He organized the entire meeting. Thank you, Kevin. To start the Global Day, I would like to acknowledge 2 awardees, or 2 awards. First is the recipient of the 2011 Ron Caroni Award from the Argentine Association of Respiratory Medicine for the highest rated presentation at CHEST. This is awarded to Elena Palma from Buenos Aires, Argentina. I don't believe Elena is able to be here yet today, but her presentation is entitled Non-Small Cell Lung Cancer in Non-Smokers. At this time, I would like to introduce for a second series of awards to be given here at the podium, Dr. Naresh Diwan, if you could please come up. He's a member of the CHEST Foundation Board of Trustees and incoming chair of the CHEST Foundation's Pro Bono Committee, and he'll present the D. Robert McCaffrey Master FCCP Humanitarian Awards.
Thank you, David. Good morning and aloha to everyone. Since the inception of the CHEST Foundation has prioritized the pro bono service in the form of volunteerism centered upon community health, continuing medical education, and disaster relief beyond the first response. This morning, we confer 4 D. Robert McCaffrey, MD, Master FCCP Humanitarian Awards, named after the founder of this special program. And he's right with us in the audience, Dr. McCaffrey. Over a decade ago, as Dr. McCaffrey, as the ACCP president, was coming to a close, he created the Humanitarian Awards to recognize ACCP members who volunteer their time and expertise to help others in need of medical and healthcare services. Little did he know that his project today encompasses a program that has conferred $1.6 million in 193 projects in 50 different countries of the world. The organizations that ACCP members support receive a monetary award from the foundation. Winning projects exemplify best practices of care and that service families worldwide. I'm honored to introduce 3 of the award-winning projects. Kathy Wilder, chair of the Ambassadors Group, will present the Ambassadors Group Humanitarian Award. I ask that each of the award recipients come forward as their projects are described, and please hold the applause until all the names have been called. Dr. Thomas Gilday the Free Medical Clinic of Greater Cleveland Volunteer Pulmonary Clinic. For over 40 years, the mission of the Free Medical Clinic of Greater Cleveland has been to provide quality health care and services free of charge to those who lack appropriate alternatives. The pulmonary clinic has a broad scope of practice and treats patients with pulmonary disease to include asthma, COPD, sarcoidosis, and lung cancer. The vast majority of the patients served by the free clinic live in poverty and have no insurance. The efforts of Dr. Gilday and other volunteers have repeatedly made a difference in the lives of these patients. The next The next awardee is Dr. Thomas Lahiri. His project, Living Extreme with Cystic Fibrosis documentary from Burlington, Vermont. Dr. Lahiri is unable to be here today, but I'll give you a description of his project. The Cystic Fibrosis Lifestyle Foundation has formally been in existence since 2003. Dr. Lahiri's involvement began even before in 2001 when he was approached by the organization's founder, a young patient with cystic fibrosis. The project, funded through this Humanitarian Award, will lead to the creation of a documentary to inspire patients with cystic fibrosis with a positive outlook and empowerment towards the disease, furthering public awareness of the disease and promoting healthy and active lifestyles. Dr. Lahiri, as indicated, is not here to receive the award. The next project is Dr. Raghu R. Sundaram. He's here with us. Dr. Sundaram is involved with a project titled Comprehensive Care Delivery to the Indigent and Poor Population Across Different Ages and Cultures. In Prakasam district in India, that is in southern India, I was told 4 to 5 hours from Hyderabad city. Dr. Sundaram has been involved in meeting the vast needs of individuals through this project since 1997. He serves as the program's medical director, makes 4 to 6 visits to India a year, and has been in constant touch with the program's volunteers. His work truly makes a difference in the lives of patients with various lung diseases and disorders, and had it not been for his efforts, these individuals would not have received the care. Education on disease prevention for all ages was a major component, or is a major component of this program. I now invite Ambassadors Group Chair Kathy Wilder to present the Ambassadors Group Humanitarian Award. Kathy?
I'm definitely honored to be here presenting this award. In 2006, the past Chairs Council of the Ambassadors inaugurated the Ambassadors Group Humanitarian Award, which was funded through efforts within our group and has given each year at the $5,000 level. We are now celebrating our 10th anniversary, and as a result, the co-chairs, Judy Brayman and Cindy Johnson, of our 10th anniversary celebration, one of the biggest goals was to fundraise $10,000 and give $10,000 this year rather than the traditional $5,000. So this is a very special year in many ways. The recipient of this year's Ambassadors Group Humanitarian Award is Dr. Peter Karsmar, and the funds will support the Taming Asthma Clinic in Providence, Rhode Island, where he serves as a dedicated volunteer. Dr. Karsmar is not able to be with us, but accepting the award on his behalf is Dr. Bill Carreo, who also serves as a volunteer physician at the clinic. The Taming Asthma Clinic provides asthma education, medical treatment, and medications for low-income, uninsured adults and children with asthma. Volunteers are dedicated to carrying out a successful, comprehensive asthma program to control the disease and impact the patients' and families' health and well-being.
Let's give all these award winners a big round of applause. I'd like to invite Dr. Gutterman to come back to continue with the program. Thank you.
Last year, the Federation of International Respiratory Societies, that represents 7 individual societies on 6 continents, organized and celebrated the Year of the Lung, which was designed to increase awareness and promote lung health. One highly successful component of that year was World Spirometry Day that was held on October 14th last year, where participants from around the world checked their FEV1s and vital capacities. And today we are taking advantage of the 2012 year being an Olympic year, and will again host a World Spirometry Day on June 27th. So in parallel with the tradition of the Olympic flame being carried to Greece from Greece to the hosting country, FERS societies, the Federation societies, have been transferring a handheld spirometer between its international members. And this is the gold-plated, actually gold-painted, authentic spirometer that has come all the way from ERS to ACCP in this authentic airline toiletry kit bag. It was passed to me by Klaus Rabe in Amsterdam at ERS meeting last month in a highly emotional ceremony. And it's my honor to hand it off to the next FERS member, the Asia Pacific Society for Respirology, which will hold its meeting in Shanghai 2 weeks from now. So Professor Miri Ip, the president of APSR, is going to accept this in recognition of World Spirometry Day. This year we are blessed with 2 keynote addresses to highlight the extensive activities of the college in our collaborations with China. We are honored to have as co-chairs Dr. Chung-Shui Bai, the ACCP regent from China. Dr. Bai is director of the Research Institute in Fudan University. He is also professor of medicine and chairman of the Shanghai Leading Academic Discipline. He is vice president of the Respiratory Society of the Chinese Medical Association, and president of the Respiratory Society of the Shanghai Medical Association. He is chief editor of both the International Journal of Respiration and Perspectives of Respiratory Medicine. And he will be the co-chair of this session. With him is Dr. Renli Chow, who is professor of pulmonary and critical care medicine at the University of Southern California. Dr. Chow has provided critical leadership in developing our educational efforts in China. So I'd like to have Dr. Renli Chow come up first to introduce our first speaker, Dr. Wang. Renli?
Good morning, everyone, and welcome to the international opening session. It's both my great honor to host this session on behalf of ACCP and a personal pleasure to introduce our speaker, Dr. Chen Wang, who is a longtime friend of mine. As you may know, ACCP has been reaching out to China over the last few years. And every year we send a delegation of speakers in China to co-sponsor a series of CME conferences. And with, of course, with our Chinese colleagues who are all here, Dr. Bai, Dr. Wang, and Dr. Cai sitting somewhere in the back. And then I was happy to facilitate this interaction. When we proposed this session to ACCP, the goal was simple, just to enhance our tie with China. And I'm a Chinese, but live in Los Angeles. So I'm very happy to facilitate this interaction. It's a long-distance interaction across the Pacific Ocean. But then, later on, Suhail kindly put me on this ACCP leadership. So all of a sudden, my vision became bigger. So I immediately see the real significance of this session. As you can see from the map, United States, America, and China are very far apart in the world. And then with different history, tradition, and culture, everything. But it's a politician's job to find the difference and then exaggerate it. This is for their benefit, otherwise they would be out of a job. But to us, the medical professional, if medicine are practiced differently in different parts of the world, we're not doing a good job. So the goal is to set the same standard. To us, people are all human, and human physiology are all the same. I think even mentality is the same. It's just some people want to find a difference, some people want to find a similarity. So with that, I think it's also to our benefit to have the same medicine practice all over the world. Otherwise, simple, we cannot sell ACCP guideline outside America. So with this, a few words about our speaker, Dr. Chen Wang, who is sitting here. You will see him in a minute. Dr. Chen Wang is the president of the Chinese Society of Respiratory Medicine and has just been re-elected for the second term, so he will serve for another few years. And he is also the president of Chaoyang Hospital, where I worked, and we know each other from there. And then later become Beijing Hospital president. That's where Chinese leaders go for medical care. He's really the VIP in the medical field. Besides that, he's also the director of the ad hoc committee during both the SARS epidemic and H1N1. He's a frontline player in both disasters. And he's also, over the last few years, several important publications appeared in journals such as CHEST, New England Journal of Medicine, Annal of Internal Medicine, and he's the principal investigator in at least half of this research project. So as you can see, he's successful in as an academician, as an administration, clinician, and a scientist. With a background like that, you don't really need an introduction. You will see for yourself from his talk. So without further ado, I present our speaker, Dr. Chen Wang, from Beijing, China. David was really worried for his leg.
So it's my great pleasure to be here. It's my great honor. And thank you so much for Dr. Gutman for inviting me here. And the topic I will deliver here is something about the opportunities and challenges for both Chinese healthcare and medical and respiratory medicines in China. And can you show the slides? And two parts in my presentation. The first one is the overview of the healthcare situation and the healthcare reforms in China. I'd like to give a comparison between U.S. and China from this table. We can see the similar area. May I have a lesser pointer or some? Okay. We have a similar area and much more population in China, and urban and rural areas. We have more population in rural areas, and the GDP in China is 1/3 of than in U.S. But GDP per capita is much lower compared with what in U.S. And the health expenditure to GDP is 5%, and U.S. is 17%. So on the other parameters we can see here. And the major health indicators we can see in this table. There's also still a big difference between China and the U.S. More advanced in U.S., such as maternal mortality, infant mortality, and other major health indicators. We can see the difference between these two countries. But compared with China itself, we can see a very significant improvement of health status in China. So here's the maternal mortality for the last 2 decades. It's from a high level to relative high level to a much lower level than before, and also the same changes for infant mortality. And also the improvement of the health status is very significant, we can see here. And the China's population's average life expectancy increased very, very significantly. So we can see that the healthcare system has progressively having a positive way. And many communicable diseases has been either being eliminated or under control. And also the health of the Chinese populace has improved significantly. And from these slides, we can see that the percentage of the health expenditure over GDP increased from 3% to 5%, but simultaneously, the health expenditure increased so significantly. What I should emphasize is this data showed here. We can see the economic burden of disease is increased simultaneously with the GDP increase, but the ratio of economic burden of disease and over GDP increased more significantly. So the EDP, I mean the economic burden of disease, increased faster compared with GDP. So it's an issue we have to face into. And the structure of health expenditure, we have three proportions of the health expenditure here. And the first one is a personal page, and the second one is a social payment, and the third one is a government payment. In past years, it's a very high percentage of the personal payment. So it's a very heavy economic burden to the patient and his family. And this curve shows the aging of tendency of aging of population tendency in China. At present, there's about 12% of elderly percentage of the elderly in China, and this time is 17 in U.S. But this percentage will grow up in both in Chinese and U.S. To the year 2030, this percentage will be 24%. So we have a close point with U.S. and the Chinese. But after that, after year 2030, and the percentage growing more faster in China, so a heavier burden, health burden China will face for. So in past 30 years, there's a rapid social changes in China, and also simultaneously the rapid changes in lifestyle happened. And with the industrialization and urbanization and the people aging, all these have made the dramatic change of lifestyle here. And so the loss of lack of accesses, high salt intake, and over consumption of oil, cooking oil, and tobacco use. So all of these lifestyle changes will cause a very severe health issue. Of course, everybody knows that the smoking rate is so high in China. And what I've emphasized is 740 million people exposed to second-hand smoking. And it's also a very severe public health issue we have to face into. And about disease spectrum, we can see that the cause of mortality here is most of the cause modality is because of the chronic disease. So this spectrum is characteristics for Chinese health status. So we can summarize the challenges for healthcare in China here. One is shifting of the disease spectrum, and then increasing the healthcare expenditure, and the low coverage and low payable level of medical insurance systems. So for patients, it's maybe an affordable personal payment, and inefficient use of healthcare resources and the higher standard of healthcare. So it's all of these give us challenges. So because the time limit, I just have a brief introduction of China's healthcare reform. And we have 5 key tasks here. The first one is improve primary or community care system. And the second point is the strengthen national disease prevention and control system. And the third is expedite the construction of basic medical insurance system. And fourth, establish national system of essential drugs and promoting the reform of public hospitals. So after the medical health reform has been initiated, a big change, some changes we can see in past 5 years. One of these changes is the development of medical insurance system, and we have urban employee basic medical insurance and urban resident basic medical insurance, and a new rural cooperative medical insurance. So in past 5 years, the population covered by these 3 sort of medical insurance system increased significantly. So as a result, the proportion of the self-paid health expenditure decreased from almost 15% to 35%. So it's still relatively higher, but it has been decreased. For part 2, I'd like to talk about some opportunities and the challenges for respiratory medicine in China. I'd like to give a brief review of the development of respiratory medicine in China. I'd like to divide this into 3 stages. And stage 1 is the main task of this stage is we should do some work for prevention and management of tuberculosis. And stage 2 is our main task is to deal with bronchitis, emphysema, and copulmonary. And the third stage started in the middle of the 90s. So we have established a modern respiratory medicine system and a comprehensive system for treatment, prevention, and research of all respiratory diseases has been started. And the training program for respiratory specialists in China listed here. When the medical student graduates from medical school, and he or she will receive the 3 years residency, and after that, a fellowship as a special pulmonary fellowship for 3 years, and then pass the examination, he or she will get the certificate of pulmonary specialist. And up now about 11,000 respiratory specialists in China. It's just a draft data, not exact data. So respiratory disease has been a major health threat in China. We can see the 2 weeks prevalence rate and respiratory disease ranks #1 here. And we can give a review to past 2 decades. And in the mortality of in rural area, the respiratory disease ranked #1 here. And in urban areas, it ranks #3 or 4 here. And as a burden of diseases, if we use the disability-adjusted values here, and we can see only COPD and lung cancer is caused 1/4 of the disease burden in China. And also, for the different diseases respectively, we can see the COPD and lung cancer and low respiratory infection and tuberculosis plays a very important role for the disease burden. So research is so important. I'd like to give some highlights of the Chinese medical research in the field of respiratory medicine. And we have a painful memory of the SARS in year 2003. It's a so severe crisis we have to face into, but at that time, we don't think it's organized very well. But the situation has changed a lot. When we're facing the 2009 H1N1 pandemic, the situation has changed a lot. And we have to do some scientific research work at that time. And here shows the descriptive study of the new 2009 pandemic influenza A in China, the clinical features of the Chinese population. I think it's a very important descriptive medicine data. And everyone knows that vaccine is the most powerful measure for control the communicable diseases. And the novel influenza A vaccine has been developed in China and get a good effect. And after a long time use of this vaccine, we can see the safety is good for this vaccine. And a newly published paper in the Annals of Internal Medicine showed that we also have an observation study of we have RCT on the traditional Chinese medicine. How about its effect or not for treating the H1N1 influenza? So we can see that for control group, the fever time is 26 hours, and if we use Tamiflu, it's shortened to 20 hours. But if we use traditional Chinese medicine herbs, it's shortened to 16 hours. And we also have a combined group. We both use Tamiflu and the traditional Chinese medicine herbs. We can see all these 3 treating groups have a significant difference between the control group. So as for VTE, about 10 years ago, the VTE is a rare disease in China, but according to our series of epidemiological survey in China, we can see that the incidence of ACT is very similar in Asian population and compared with Caucasian population. It's also a common disease in China and I think in Asian population. Another research I'd like to mention here is about low dosage research of RTPA for PTE. And our research shows that half the dosage and a similar efficacy and less bleeding can be this effect can be seen from our research. So I think the 5 million milligram regimen is a more suitable regimen for PE thrombolytic therapy. And we can see from these pictures that significant improvement has been made in the field of pulmonary embolism in China. We can see the number of diagnosis cases here increased very, very significantly, at least 10 or to 30-fold in past 10 years. And the inpatient mortality decreased from 24% to 30 to 8.7%. So this shows the improvement of the diagnosis, and this shows the improvement of the treatment. And according to research, and here's the increasing of all Chinese medical papers, the amount of all Chinese medical papers increased. And this red curve shows the increasement of the papers on VTE. So it's a hard field of research in China. It's a very significant improvement, I think. As for the Chinese, COPD is prevalence according to Dr. Zhong's research is 8.2%. So it's a very common disease in China. And we can see that, and we can do, and from Guangzhou Institute of Respiratory Medicine, also do some very good research work, such as they find that the biomass fuel is a high risk factor for COPD in Chinese population. And the other survey from my team is we can see depression and anxiety is also a risk factor for the acceleration of COPD. And also the community, we have, and in Guangzhou, we have also do some community-based interaction, and we get some good effects from this intervention. And we can see, I have traced some medical literatures here, and here's a number of medical literatures in the field of respiratory medicine published from US. It's a huge number. It's much higher than other countries. But and China, in the early 90s, almost none Chinese papers published in international journals. But in the recent 10 years, this number increased very, very significantly. And up to the year 2010, it ranks number 4 in the world. So as the president of Chinese Society of Respiratory Medicine, I'd like to push the cooperation between Chinese Thoracic Society and ACCP. So I'd like to, maybe we can find some fields, such as we can do some international guidelines development. You know, the 1/4 of populations in China. So if the international guidelines involve the Chinese as expert, I think it's very important. And maybe I can do some joint research project. We can co-sponsor some joint conferences, and we can initiate some respiratory fellow training program or visiting a scholar exchanging program. So that's what I think about. We can push a collaboration between ACCP and the Chinese Society of Respiratory Medicine. So many thanks in my heart this time, and thanks for the committee members of Chinese Society of Respiratory Medicine. They give me so many help. And thanks so many of my Chinese colleagues here. They have done a lot for pushing the development of Chinese respiratory medicine. And Dr. Qiao Ren Li gave me so many help in the past several years. And my team members, Dr. Xiao, Dr. Zhang, and Dr. Wu, Dr. Cao, Dr. Xiao, something like that. Thank you so much from my heart. And thank you for attendance.
Thanks, Dr. Wang. And I want to also mention one point. You know, Dr. Wang prepared for 70 minutes talk, and then he has to shorten it to such a concise review. And he worked till 3 o'clock this morning, and then he practiced English afterward. So his time is okay, so we'll take 1 or 2 questions. But I want to point out one point there. One point struck me. You know, the healthcare expenditure in the United States is about 1/5 of our GDP, while the population in China is about 5 times of ours. So in another word, if the Chinese people are cared for in the United States, we wouldn't have any money left to make bombs. So that is a very important point. So instead of teaching something, we may learn something here. Anyway, 1 or 2 questions, please.
I I was amazed that with the 5% healthcare expenditure, you can increase your life expectancy so super proportionally. This is really impressive figures, and I think you should be congratulated what you've done over the last couple of years. I mean, deep respect. The point remains that 70% of the population is smoking, and I was missing in some of your medical sort of perspectives and where you need to go. I think smoking should be on your agenda probably much more than you had time to elucidate, because you had to cut down from 70 minutes to 30. But I basically believe that this probably is one of the major challenges. I think there's an economic factor involved in this, in production of tobacco products. But I think it's our, let's say, responsibility to do something there very, very actively, also in research. I just would welcome your comments on that.
Thank you for your comments.
That was an excellent presentation. One of the points on the slide indicated that there was a disparity between either the mortality rates in the urban and the rural population. Can you comment whether is it the access to healthcare resources, or what would be done about this disparity?
So it's a difference between urban and the rural areas, the maternal mortality and infant mortality, because of the medical resources shortage relative shortage in the rural areas. So in past 10 years, one of the very heavy tasks for us is for push the development of the rural areas for their medical care in rural areas. So we set up many county hospitals. We push the construction of county hospitals, and in rural areas we set up the community clinics. So it's a huge population in the rural areas in China. So the medical resources distributed there is relatively short compared with the urban area. So that may be the reason of the mortality between the urban and rural area, I think. So as to the issue about smoking, I think is really a heavy work I have to face into. You know, my professor, Dr. Wen Xinzhi, he was called as a grandpa for tobacco control in China, called by WHO. And he had started the Chinese tobacco campaign about 40 years ago. And we have pushed this movement very, very hard, but it's really a difficult work to do, because one of the main economic income from the tobacco industry. So the government have to facing the pressure from the tobacco industry. So it's why I think it's a very important reason for developing countries. If the government gets some economic income, it's very important. But I have so many advice to leaders of Chinese government to tell them it's harmful. Yeah, it's compared with the side effects of tobacco smoking, tobacco industry income. You should pay more as a health expenditure. So more and more Chinese leaders accept this opinion. So in the next 5 years, we have a national project for tobacco control. We want to have totally forbidden in public places for tobacco, but of course it's not easy. But we have to try our best to do that. Thanks.